Oh, yes, absolutely. If you reframe your thinking about migraines as merely a nerve problem, you can think of, say, your funny bone. If you hit your elbow, which most people have done, they've experienced this pain that surges into their forearm and then tingling into their fingers. You know what it's like to have a nerve-type sensation that has a source here but spreads to another area. And if you think of your head and face that way, that you have a nerve problem that's deep-seated in your neck that spreads up, over, and down into your face, then you have the proper interpretation of migraine, I think. What happens with migraines is it's like a campfire, say at the base of your skull, that turns into a forest fire in your head and face, and it can encompass other nerve systems, which include vagus primarily. The vagus nerve is responsible for dizziness and lightheadedness, and also nausea. So that's if it's a raging forest fire. And this is not a disease. This is a rapidly reversible nerve problem in my experience consistently. And I know that that's an outlier view in the medical community, but that's not my view. After doing this, and at last estimate was 27,000 patient visits over 10 years, that's been the consistent observation. So I'm confident about that. The truth kind of falls out. It's not like I'm pontificating, looking at an MRI or CT scan of the head or blood work and trying to discern, gee, is that really causing this migraine, or is this a vessel problem? I don't have to think that, because I know better after watching this for so many years, day in, day out, doing this work myself on real patients. And it doesn't seem to matter whether it's a classic migraine or what they call a tension type migraine. Cluster headache, say, typically goes on one side into an eye. Hemiplegic migraine, trigeminal neuralgia. It doesn't matter. These all appear to have the same origin because they all respond to the system. There was a study that I did with an MD colleague, and we presented it at a headache symposium, and it tracked trigeminal neuralgia, which are called suicide headaches. We had 10 patients with that diagnosis, and they had one-sided symptoms on their face, typically down like this on the side of the face into the teeth. A horrifically painful problem. All 10 of them had excellent outcomes, and all 10 of them had this nerve problem that I'm talking about. And that's like the worst that you can think of, a migraine. That's about the worst that it gets as a full blast trigeminal neuralgia. Well, I'm a clinician. I'm not a researcher. Seeing patients day in, day out, I have started research projects, plural, with an MD colleague who's also a headache specialist, and it's Herculean to carry it off. So it requires funding, it requires a lot of time, and a team really to kind of put it all together, and we're not quite there yet. We've got a quasi-team, but it's going to take more time to publish it, and it is foreboding to find out from somebody that we're talking to recently, the head of family practice at University of Texas. He trains the interns, and he said, you realize, of course, that once you publish this stuff in a peer-reviewed journals, that it's going to take 14 years before it's in clinical practice, like actually in the clinic and actually showing this to patients or sharing this with patients. That was not the most exciting news that we'd ever heard to motivate us to move forward with clinical research. Even in the absence of neck symptoms, it appears to be a disc bulge in the lower neck that cascades up to the base of the skull area, up into the head and face. And I watched this symptom response in an average of around 14 patients per day over the past 10 years. So I figured out that I'm working with the source, because that is the area that I'm working with, and that's what rapidly reverses these symptoms. Yes, there is a quick screening process. One is a symptom pattern, and that would be that, let's say on the days that you don't wake up with a terrible headache or migraine, that you'll most likely notice that your symptoms are better in the morning, progressively worsening as the day goes on. So around 1 or 2 o'clock in the afternoon, you would notice that your symptoms would be cascading in your head and face and becoming worse. That implies a mechanical, like head on your neck, kind of compressing the nerve, kind of pattern than something in your brain or some blood vessel problem or some other cryptic problem. And also on the days that maybe you wake up with terrible symptom intensity or a migraine, be thinking neck position and mechanics instead of something mysterious. You'll probably also notice even on those days that your symptoms, once they're super intense, that they will start to decrease in intensity kind of throughout the morning and then start to ramp up again in the afternoon and evening. There's also something called a JAM test. I made these up some time ago, but they seem to be effective, kind of like the symptom pattern that I just mentioned. And that is that you can slide your chin in kind of like a double chin and hold that and start to move your head back, and bam, you'll most likely hit the problem in your lower neck that this system goes after. It's kind of a pulling, tightness, stress sensation, an obstruction to extension or going backward that is not supposed to be there. Again, it looks like this and then that. And that is not normal to feel an obstruction when you do that. That should move fluidly, and you shouldn't have any symptoms whatsoever when you do your chin tuck head all the way back, because your neck is normally designed to be able to do that. And the third thing is actually to shut your symptoms off. It usually takes anywhere from 30 seconds to as long as a minute and a half or 2 minutes. It's called a slump test or the fast test, either one. And I don't have time to go into that on this video, but just to let you know, that third test is to experience rapid reduction and or abolishment of head and facial symptoms, so you'll see for yourself if you're a candidate or not for this kind of system.